Hey there, and welcome back to another episode of Community Paramedicine. This week's topic is going to be lab values. I know everybody's favorite. Most of us don't have lab values memorized. Most doctors don't have lab values all memorized. So this is definitely one that is a little more complicated for us. I am hoping that this lecture will be able to highlight the main ones that you need to know when it comes to treating your patients in the field, and then the ones that they tend to test on the most. So that is my goal with this one. I will do my best to not get tongue-tied. So our lab tests give us more than complete pictures, or give us a more complete picture than a history and a physical exam alone does. We know that they're very essential in confirming or ruling out what is actually going on with our patients. Most often, these blood and urine tests ordered by a physician in the ER. For us, knowing what these tests mean will help us anticipate what the hospital will be looking for, and also help us explain things to the families, as well as help critique things for them at home. We're going to start with the complete blood count. It's too early in the game for that. This is the CBC. It's one of the most common and useful lab tests. It can detect anemia, bleeding problems, infections, allergies, even bone marrow disorders that patients may have. So we're thinking of this as the big picture test. So it's about what's happening inside the body, the big picture. So our complete blood count, we have RBCs that carry oxygen to the tissues. Our hemoglobin is the protein that actually carries oxygen and carbon dioxide. Our hematocrit measures the percentage of red blood cells in the blood. Our platelets are also vital for clotting, as we know, and low platelets could mean that our patient could have a bleeding risk. Our white blood cells back in there are ones that are infection fighters. So we're going to break it down a little bit. So our red blood cells are the formed elements in the blood that carry oxygen in the bloodstream. The normal range for red blood count, or the red blood cells, is 3.9 to 5.5. That's our general range. Hemoglobin, or HGB, is the protein on the red blood cells that carry oxygen to the cells and carbon dioxide away from the tissue. The normal hemoglobin range is 14 to 18. For males and 12 to 16 for our females. Our hematocrit is the percentage of red blood cells compared to the entire volume of blood. So usually about 45% to 52% for our males, and for women it's less than that. It's 37 to 48% for us ladies. Our platelets are the colorless blood cells that circulate in the bloodstream to aid in clotting. Our normal range is about 150 to 350. Okay, well, let's spot forward. There we go. Now it's working properly. Our white blood cells, we know, are infection fighters. So they get used up quickly when our body is under attack. Our normal white blood count is between 4,500 and 11,000 per microliter. Outside of that range, you're looking at a possible infection, sepsis, inflammation, or possibly other diseases that could be going on. A CBC with differential breaks down each type of white blood cell. This helps pinpoint whether the issue is allergy, infection, or even an immune reaction. It's like zooming in for a more detailed look. Our types of white blood cells tested would be our neutrophils, also our band cells, our T's and B's, our lymphocytes, monocytes, eosinophils, and basophils. Each one does tell a different story about what's happening inside the body. For example, our eosinophils, we have a rise in allergic reactions, or it could be a possible parasitic infection that is going on inside. Chronic illnesses or treatments can affect all elements of the CBC. Since blood cells are made in our bone marrow, low results across the board may mean bone marrow disease or suppression from treatment like chemo. If our white blood cells are elevated, the CBC with differential helps sort out whether it's infection or allergy. That's why just knowing our white blood cell is high isn't enough. We have to have that breakdown. So the CBC is about the formed elements of blood. Now let's kind of move on to the basic metabolic profile, better known as our BMP, and that looks at what's circulating in the blood instead of our cells. Our BMP test measures the glucose, our BUN, creatine, electrolytes, bicarbonate, as well as our CO2. It helps assess how the body metabolism or our metabolism is actually functioning. So instead of cells, we're kind of thinking more chemistry with this one. The BMP measures the concentration of our glucose, our BUN, which stands for our blood urea nitrogen, creatine, which is often used to calculate the glomerular filtration rate, or GFR, the electrolytes, sodium, potassium chloride, everybody's favorite sodium potassium pump, our bicarbonate ion level, and carbon dioxide level. So that's looking at all things like our blood sugar control, kidney functions, acid-base balances, which ties into hydration as well as our respiratory status. Our glucose levels guide our diabetic management of our patients. We know we keep a close watch on those for our diabetics in the back of the truck, same thing in the field. We need to look at those labs. Our fasting tests are always going to be the most accurate. Elevated glucose can also give us a hint at possible kidney impairment that the patient could potentially have or be going down that route. Glucose is the most important carbohydrate that we have in our bodies. It is the most readily usable form of sugar that we have, as well as energy. Our normal range for fasting glucose is 70 to 100. For non-diabetic patients, the upper range, 2 hours after a meal, would be below 140. So 2 hours after a meal for non-diabetic would be below 140. Most commonly, glucose tests are performed to aid in the management of patients with diabetes. Our hypoglycemia can lead to acute altered level of consciousness and death. Hyper can lead to diabetic coma, metabolic acidosis, and severe dehydration. Remember our 3 Ps, polydipsia, polyphagia, polyuria. When assessing the patient with diabetes, a fasting glucose test is the most optimal. Our best indicator of the patient's baseline, as the body has utilized its glucose stores during the fasting period. That's usually about 8 hours prior to the test. The glucose test also has another benefit. It can indicate the renal impairment that we mentioned shortly there beforehand. Patients with renal impairment are unable to clear the glucose effectively. A high glucose level in the blood, but not in the urine, could indicate renal insufficiency or even failure that has occurred. The blood glucose test is a basic one that can be performed by community paramedics and can help in the monitoring with management of patients with chronic conditions. Unless otherwise indicated, the blood glucose devices used for point-of-care testing are designed for capillary sampling. So, phalanges. The recommended procedure for obtaining a cap sample, you guys know that, preparing the site, finger, heel, wiping the alcohol, wait for it to dry, don't blow on it, and get that one single picture, and the one single puncture, wipe it away, and then get the second one, and then get your sample. Although the glucometer provides a quick check of the patient's blood glucose level, the procedures that deviate from the preceding steps can yield inconsistent results, so always be consistent with those. So always do the same thing every time. On to our BUN. I love the BUN. So if you only know a few, I think the BUN is one that helps you in the basic field as a paramedic a lot. So BUN, which stands for your blood urea nitrogen. So our blood urea nitrogen BUN, it is a product of normal protein catabolism and has a normal range of 8 to 23. In a patient with a chronic condition, an elevated BUN could mean the kidneys are no longer able to pull out the urea from the bloodstream. When combined with a creatine level, this information is incredibly useful as an indicator of compromised renal function. Elevated BUN levels may be caused by conditions other than renal dysfunction. Other events besides increased protein ingestion may potentially lead to excessive amounts of protein in the body that need to be catabolized. Elevated BUN can result from tissue damage that happened with trauma or even burns, or could also come because of blood loss. Our creatine is a waste byproduct of muscle breakdown. It is eliminated through our kidneys. Measurement of creatine is one of the best routine labs for revealing information about renal dysfunction. It goes hand in hand with our BUN. It is also used in the calculation of our glomerular filtration rate, our GFR. The normal range for creatine is 0.6 to 0.12. There are some variations depending on the lab performing the test and the patient's gender as well as their age. When an elevated creatine level is combined with an elevated BUN value, it indicates a patient is experiencing some sort of renal compromise. The next step would be to review their GFR or have one run it if it's not already been performed for this patient. So maybe send them out for some follow-up labs. Our glomerular filtration rate, GFR. To test how well the kidneys are actually filtering waste and toxins from the blood, a GFR or an estimated GFR, which is called an eGFR, should be ordered if it's not already been reported. The GFR is the rate at which our kidneys can filter the creatine from our bloodstream. When functioning normally, the kidney should be able to filter all of the creatine out of 100 milliliters of blood per minute. So they should filter 100 milliliters of blood out per minute. A simpler and less time-consuming method, that's the eGFR, can be used to calculate the GFR using tests that are already routinely performed and information that is readily available during the patient contact. So to calculate the eGFR, the lab collects the data on the patient's age, their gender, their race, and their creatine level. This data is entered into a formula and estimates the GFR. Thankfully, this was not on the IBS certification course, so you're good with that one. Hopefully. Then we go on to our basic metabolic profile, including our electrolyte panels. You guys should be very familiar with our sodium-potassium pump at this point. We know how vital these electrolytes are in our patients, and if they just get a little bit out of whack, it could definitely derail them. So our three electrolytes in the BMP are the sodium, potassium, and chloride. Sodium is the main one. It's a predominant extracellular electrolyte. It's important for nerve transmission and the cardiac cycle. Potassium is primarily found intracellular, in the intracellular environment, and plays a critical role in the cardiac cycle. Chloride is found in the extracellular spaces and combines to neutralize cations. Those are positively charged ions. It also binds to the sodium ion, forming the sodium chloride molecule. The concentrations of the three major electrolytes, the sodium, potassium, and chloride, change in different disease states. Shifts in these levels can tell us a ton about disease states as well as dehydration. So our sodium, the axiom water follows sodium. Water does follow sodium. This suggests the kind of shift that happens when the body uses sodium to manage its systemic fluid levels. The normal sodium range is 136 to 142 milliequivalents per liter. It's 136 to 142. Hyponatremia, hypo being low, hyponatremia, our low sodium levels, can be caused by a multitude of things. More commonly would be overhydration, excessive sodium loss, which could happen with our congestive heart failure patients, renal failure, liver disease, or patients that are on diuretics, our Lasix. Our hyper meaning high, hypernatremia, high sodium levels, can occur in patients with closed head injuries as a result of the treatment for this trauma. So our 3% hypertonic saline solution can also cause it, can also be caused from dehydration as well. Potassium. The body can lose potassium in multiple ways, leading to the killer hypo-K. So hyper-K and hyper-K, you need to be familiar with both hyper and hypo. You can see them on EKGs as well as those direct reflections. So GI issues, vomiting, diarrhea, intravascular stores of potassium can be shifted into the cells by insulin, leading to our hypo-K. So potassium is a critical electrolyte in our cardiac cycle. It is measured in milliequivalents per liter. The normal level of potassium is 3.5 to 5.0 milliequivalents per liter. This is another one that I think that all medics should know through and through. Our diuretic therapy often produces hypo-K as a side effect. So patients taking diuretics may also be prescribed potassium supplements. They generally go hand in hand to help manage their levels of this electrolyte. Hyper-K is defined as a serum potassium concentration greater than 5 millicues per liter. So moderate would be 6 to 7, and then our severe is going to be above 7. and forms of hyper K. These are considered life-threatening and require immediate therapy. Hyper K can result from cellular lysis, such as with our crush or burn injuries, or it could be because of drug administration, such as our ACE inhibitors as well. Hyper K also comes from metabolic acidosis or poor kidney excretion. Our dialysis patients are at high risk. I'm sure you all have transported the dialysis patient that has hyper K. Remember, changes in potassium levels, even a little bit, can be life-threatening for our patients. On to chloride. Chloride is an anion, meaning it is a negative charge. It has that negative charge. It's often found combined with electrolytes that carry a positive charge, which is our cations, such as sodium and potassium being the two famous. Chloride is most often associated with sodium. The normal range for chloride is 96 to 106 millicues per liter, milliequivalents per liter. Our chloride concentrations may be low due to the use of diuretic therapy, such as medication that can cause our fluid shifts by shifting our sodium stores. It's not as dramatic, but it is still part of the overall fluid in our electrolyte picture. Then on to our bicarbonate and our carbon dioxide. So like our chloride, our bicarbonate, or HCO3, is an anion that is found within our blood. It is closely tied to carbon dioxide, which is our CO2, through the acid-base balance system. Yes, you do have to know acid-base balance pretty well for these tests. So our bicarbonate acts as a buffer to that metabolic acid. When our bicarbonate and carbon dioxide are combined, they form carbonic acid, which dissociates into water and carbon dioxide, and it is then exhaled from our patients as a waste product. The more acidic the system, the more bicarbonate is then used to buffer the acid that we have. Carbon dioxide is a respiratory acid. It is reported in the millimeters of mercury, so our mmHg, millimeters of mercury, and indicates how much pressure the carbon dioxide is exerting in the atmosphere in the area being measured. The normal value of carbon dioxide is in the range of 35 to 45 mm per Hg, or our millimeters of mercury. A value greater than 45 indicates the patient is in respiratory acidosis. A value below 35 indicates the patient is in respiratory alkalosis. Some causes of metabolic acidosis, most commonly being sepsis and dehydration, and some common causes of metabolic alkalosis could be rising bicarbonate concentrations and renal dysfunctions. Okay, on to our B type, I can never say this one. Let's see if I can get it today. Natriuretic peptide, we're just going to go with it, our BNP. We're going to call it the BNP. So measurement of the B type, or BNP, or brain natriuretic peptide, is measured to identify the presence and possibility, the severity of congestive heart failure. So BNP helps measure CHF. In a patient with CHF, an intracardiac pressure builds. The body then needs a mechanism to relieve that excess pressure that we have. One of these mechanisms is to reduce the intravascular fluid by increasing both sodium excretion and water excretion. Our BNP inhibits sodium reuptake in the kidneys and increases the GFR. Elevated BNP levels indicate that the heart ventricles have experienced either excessive fluid or excessive pressure. So BNP values are correlated with CHF as follow. So greater than normal. But over 200, it likely means we have compensated. So up to 200, we have compensated CHF. Up to 200, compensated CHF. Greater than 200, but not quite to the 400 range, that means we have moderate CHF. So 200 to 400, moderate. And then anything above 400, we are in the moderate to severe CHF. When we combine with other clinical presentations, or when this is combined with other clinical presentations of either right or left-sided heart failure, these are very telling lab values. Our serum lactate level, lactic acid. Under normal conditions, the cells of our body get their energy from the citric acid cycle, where oxygen is the final recipient of our electron transport train. When the cells of the body become hypoperfused, they may need to use anaerobic metabolism to create energy. Anaerobic, meaning without oxygen. The energy yield from this process is much less, so only 2 ATP, we're going back to chemistry here, they only generate 2 ATP molecules, and one of its byproducts is lactic acid, also known as lactate. At levels greater than normal, so 5 to 15 milligrams, some conditions increase oxygen demand and at the same time decrease blood flow to the body's systems. These conditions could be severe hypoxemia, hypovolemia, could be trauma, sepsis. Shivering can cause it as well as seizures. If the body cannot compensate for these changes, then lactic acid will build in our system, and that results in metabolic acidosis. Most causes of increased lactate levels can be determined during the patient assessment. However, sepsis can be difficult to assess and often has a very poor outcome for our patients. Troponin is another one we should all know. I know y'all are familiar with it. The word, maybe not the values, but be good to get familiar with troponin levels. So troponin is a protein that plays a role in muscle contraction, including contraction of our heart and our skeleton as well. Troponin released into the serum only when a muscle undergoes cellular damage and necrosis. So it is only released when it undergoes damage, such as a heart attack, an AMI. The normal range for this protein is 0 to 0.4, so it's okay to have a 0 troponin. But specific subtypes are also measured. In a heart attack, our cardiac troponin is released, so that is called a CTNL. CTNL tests for accurate myocardial infarctions. At 6 hours after an acute myocardial infarction, the CTNL test is 97% sensitive and 95% specific for an acute myocardial infarction. It is a dead giveaway. Our normal troponin levels are very low or completely undetectable in healthy individuals. The exact cutoff depends on the lab and the specific test that is used. There's high sensitivity versus conventional, but general references are our troponin normal is less than 0.04. Borderline, meaning there could be a possible myocardial injury that has occurred, is our 0.4 to 0.39. And likely that a myocardial infarction has occurred is greater than 0.40. So for our troponin T, the normal is going to be 0.01 to 0.02, and that depends on also the lab value. Many labs use the 0.014 as the 99th percentile cutoff for high sensitivity tests. So it's important to understand what test has been run by your lab. So any detectable rise above a lab's reference cutoff, so know what that reference cutoff is considered abnormal and usually indicates some type of myocardial injury. Our levels typically rise 3 to 6 hours after myocardial infarction, and they peak at 12 to 24 hours after the MI. They can remain elevated for up to 1 to 2 weeks after the incident has occurred. Our international normalized ratio, or INR, this could mean a blood vessel injury. When a blood vessel is injured, this damage sets off a series of events that leads to clot formation and the cessation of bleeding. That's how we stay alive. So the cascade of events is first managed by the tissue factor pathway that involves thrombin. Its effectiveness is measured using a lab value called prothrombin time, or PT, which assesses the time it takes the blood clot to actually form. The PT test is performed differently around the world with varying results. The International Normalized Ratio, or INR, seeks to standardize these results so that way treatment can be better planned. The normal range for the INR is 0.8 to 1.1. Because the INR is initially a measurement of the patient's clotting time, the higher the number, the longer it takes for the blood to actually clot. When a patient is put on an anticoagulant, such as artemisinin or warfarin, the target for INR is a range of 2 to 3. Urine analysis are also incredibly helpful. Like the BMP, it provides a wealth of information that can point to a number of pathologies, I can't speak anymore, and conditions including dehydration, renal insufficiency, diabetes, or even drug ingestion that has occurred. So we are looking at multiple factors when we do a urine analysis. So we are looking at the color. It's often described as yellow straw, pale, clear, and so on. Absent or any other constitute elements, this color is directly related to the concentration of the urine. The more concentrated the urine, the darker its color and the less hydrated the patient is. Reddish urine could mean there's blood. Brown could mean that we may have some rhabdo that is actually occurring. So another basic assessment of urine's appearance is the clarity. Is it clear? Is there floaters? Is there blood in the urine? We may have changes in the white blood count from the CBC that pop up if there's a bladder infection that is occurring. And we may see some of those floaters plus blood in that urine sample as well. The specific gravity of the urine is a chemical property that describes its density relative to water. So the normal specific gravity of urine is 1.003 to 1.035. Distilled water has a specific gravity of 1. The more concentrated the urine, the higher its specific gravity is. When our hydrogen ion concentration increases, our pH, we have metabolic acidosis that occurs. Our serum pH levels will be lower than normal at this rate. A decreased pH level can also be identified in urine in the setting of acidosis. Although urine has a much broader normal range for pH, it's usually the range is 4.5 to 8 for normal urine cultures. So our urine elevation, glucose in a healthy person, a normal range in our glucose is going to be 0.08 in our urine. Only when the serum glucose levels begin to rise does the body attempt to get rid of the excess glucose by eliminating it through the urine, such as in diabetes mellitus. It's critical to look at the whole patient when assessing urinary glucose levels. Ketones, you're familiar with ketones as paramedics in the context of diabetic emergencies, especially DKA, diabetic ketoacidosis, also known as diabetic coma. Our body does not have enough insulin to meet the demands of the system, which results in inadequate cellular uptake of glucose and hyperglycemia. Our body then attempts to rid itself of the ketoic acids by eliminating them in the urine. Normally no ketones are found in the urine, so their presence indicates ketones are elsewhere in the body. Ketones can also form through other metabolic processes such as alcoholic ketoacidosis or starvation ketoacidosis, as those that we saw like people that were on the Atkins diet phase. Most people for protein excrete about 40 to 80 milligrams of protein in their urine each day. That's pretty normal. This is usually below the detectable threshold. So the normal value for protein in the urine is generally negative. When protein is found in the urine, the causes can be organized into two categories, either renal or extrarenal. Any protein in the urine is a significant finding. Blood and hemoglobin. Blood is not normally able to cross through the glomerular membrane and enter into the urine filtrate, so its presence is a significant indicator of either kidney damage or even urinary tract damage. There are two aspects of blood assessed by the lab in urinalysis, our RBCs and our hemoglobin. Our RBCs in the urine cause hematuria, can indicate an issue with our glomerular membrane, which acts as that filter and helps prevent large particles from entering the urine. Could be the urinary tract itself as well that has the issue. RBCs in the urine can result from bladder infections, could be a neoplasm, kidney stones, trauma, or could be because of a placement of a urinary catheter. Hemoglobin in the urine, so hemoglobinuria, most often means there was a traumatic passage of an RBC through some part of the urinary system. Could be in the collecting ducts, the urinary tract, or even the bladder itself. Hemoglobin may also be found in the urine when some sort of hematologic event occurs in the circulatory system and the kidneys filter its byproducts. Our hemolytic transfusion reactions or hemolytic anemia or even a rhabdo. If rhabdo could occur, it can also show your hemoglobin in urine. So a variety of drugs can also be detected in our urine. This information can be helpful when evaluating a patient at home who may be experiencing any number of issues that are affected by prescription or non-prescription medications or drug abuse. We also have a stool test. Our stool test, I believe is how it's pronounced. Don't quote me on that. The stool test is a simple qualitative test that checks for occult blood in the stool. The sample can be collected at home or during a rectal exam at the physician's office. The stool test is useful in determining a bleeding source within the GI tract. So to determine a more definitive diagnosis, the test result does need to be correlated with the chief complaint, as well as the physical examination and other tests that they will need to go in for. On to our hemoglobin A1C. I know we're a little over that 30-minute mark. The labs has a lot to it, so bear with me. We only have a few more slides left. Our A1C is a specific form of hemoglobin in the body that becomes glycated as a result of contact with glucose in the blood. All of us have glucose in our blood. It's normal. So this glycolated hemoglobin is a normal finding, with the levels typically ranging between 4% and 5.6%. The HbA1c lab, this reflects the average blood glucose levels over the past 2 to 3 months, rather than simply providing a quick little snapshot of the glucose level such as our glucometer does for you. The results reveal the degree of control of the patient's diabetes over the previous several months, so it gives us a clearer picture of what's going on. The higher the HbA1c value, the higher the risk of developing complications such as cardiovascular disease, neuropathy, or renopathy. For people who have not been diagnosed with diabetes, the HbA1c level can also indicate the risk or the presence of diabetes. Serum lipid profiles. So we're evaluating cardiovascular risk with these. The serum lipid profile is part of a standard physical examination screening with primary care physician and evaluates the risk for cardiovascular disease with our patients. These are for patients that may have pre-existing diabetes, those comorbidities, they may smoke, or they may have a family history of arteriosclerotic vascular disease, or ASVD. The profile usually includes 4 components: our low-density lipoprotein, or LDL, and our high-density lipoprotein, HDL. I'm sure you guys have seen this on your physical report for your blood draw, if you wondered what these were. Our triglycerides, as well as our total cholesterol. LDLs are the bad ones. They're bad, the bad lipid proteins that increase the risk of cardiovascular disease. Our HDLs are considered the good fats, or the good lipoproteins, which decrease the amount of atherosclerosis in the walls of our arteries. An elevated value for LDL, triglycerides, or total cholesterol is usually indicative of an increased risk of having heart disease. Liver function profile and test. So these tests are commonly referred to as liver function tests. The liver function profile comprises a group of tests that assess how well the liver is functioning. Elevated LFT, liver function test, results are indicative of liver damage that has occurred. All right, we're going to break these down for you to the best of my knowledge. These are your normal. The normal profiles for albumin is going to be 3.5 to 5. If it's low, it could mean that you have poor nutrition, liver disease, or fluid leaking into the tissues such as edema. If it's high, it usually just means dehydration. Our alkaline phosphate, or phosphatase, which is a ALP, our normal is 30 to 120. If it's high, this generally means there could be a bile duct that's blocked, could be liver disease, or also could be a bone issue. Our ALT, our alanine transaminase, ALT, normal is 10 to 40. High levels of this could mean we have liver damage. It is more specific to the liver than your AST is. So your AST to ALT ratio is usually a 2 to 1. If we have a higher 2 to 1, we're thinking it could be alcoholic liver disease that is going on. Our AST, I'm not even going to try. Okay, I'll try. Let's see. Aspartate aminotransferase. Sounds good. Our normal is 10 to 30. High levels of this could mean liver damage, heart failure, low oxygen, or could be trauma. Found in the liver, heart, muscle, and brain. It's not just liver specific though. Our glutamol transpeptides, GGT, normal is 2 to 30. High values could mean we're very sensitive for liver damage, alcohol use, or certain drugs like NSAID overuse, aspirin, things like that. Also elevated with pancreas or bile duct problems that could cause mean a pancreas or bile duct problem. Bilirubin, thankfully I got an easy one. Bilirubin, so normal is 0.3 to 1.2. Bilirubin, 0.3, 1.2. High levels could mean liver disease, bile duct obstruction, rapid breakdown of red blood cells that could be occurring as well. So we have a direct versus indirect with our bilirubin. Our direct, which would be 0.1 to 0.3 milligrams. Our indirect could be a 0.2 to 0.9. Our high direct could be liver or bile duct issues, and a high indirect could be red blood cells breakdown. So, all right. On to our venous blood gas analysis. This gives us insight into respiratory and metabolic status. It's useful with our COPDers, asthma, CHF, as well as our diabetic emergencies. It's easier to obtain than arterial samples in many cases. Our VBG and our ABG values often correlate our pH, our CO2, our bicarbonate, our pulse ox, oximetry. This allows our clinicians to interpret results very quickly. So here we go. Let's break these down. Oximetry, our VBGs, venous blood gases, can measure our carboxyhemoglobin and our methemoglobin. These values are not the same as our pulse ox. They're not the same. For quick oxygen checks, our pulse ox is generally fine. Our pH, our venous blood is slightly more acidic than our arterial. To estimate arterial pH, we're going to add 0.035 to our venous pH. Did you know that? I didn't. I learned it while I was studying for this presentation. So to estimate our arterial pH, add 0.035 to our venous pH. So our normal pH for arterial is 7.35 to 7.45. Our VBG pH works well for non-respiratory problems like DKA. Carbon dioxide, our CO2. Normal arterial CO2, 35 to 45, the magic number. Our venous CO2 can guide care in conditions like COPD, so high CO2 retention is very common with COPDers as well as hypoventilation. And last but certainly not least for our venous blood gas analysis is our bicarbonate, our HCO3. Venous and arterial bicarbonate levels are usually very similar. Our normal range, 22.26. If the patient is hypoperfused, shock, poor circulation, ABG is better than VBG for the accuracy. All right, we've come to the end of our PowerPoint presentation. I do have a few more things to fill you in on. Just a quick review here. So our lab tests confirm what we see in the assessment. So always do our assessment. Our CBC tells us about infection, anemia, clotting. BMP looks at your kidneys, electrolytes, and acid base. Our cardiac markers such as our troponin, BNP, and lactate. These are critical in chest pain, heart failure, and sepsis alert patients. Our LFTs reflect that liver health, alcohol use, our biliary problems. Our VBGs and ABGs help us understand pH, CO2, and oxygenation. We bridge the gaps between home and hospital. We do. That's the goal. So understanding labs helps us identify problems before they become emergencies, support our patients in managing those chronic illnesses at home, and reduce those avoidable ER visits and readmissions. Remember our diabetic patients, A1C glucose trends. We need to reinforce medications and diets if we start seeing that. For COPD, CHF patients, our BMP, bicarbonate, CO2, we may be able to spot the flare-ups early with these patients. For geriatric care, monitor electrolytes and hydration, prevents falls, confusion, and readmissions from occurring. Our liver disease patients, our albumin and bilirubin, we can track the progression in medication and see how it's impacting them. So your role as a community paramedic, so you need to be able to explain what lab values mean in plain language. All of this is gibberish to a basic layperson. Everything that I just said would probably make their head explode. So be able to break it down in an understandable, manageable way. Then also help advocate, help them connect with their primary care specialists that they may need. We're also trying to catch red flags before they turn into spiraling out of control crises, and work with their families and our caregivers to help support the ongoing care that they need. Treat the patient, not just the monitor, but let the numbers guide your teaching and your planning. Every lab value is a chance to reinforce healthy choices for your patient. Our goal, keep the patient safe, stable, and at home whenever possible. That's all I got for lab values. I know it was a lot. Y'all hang in there and holler at me if you have any questions, thoughts, feedback, concerns, snide comments. Have a great day.